Hey guys, I'm Eddie Joe, and this particular journal club-ish that I'm going to be doing today is going to be talking about this really cool article called Pantoprazole in Patients at Risk for GI Bleeding in the ICU. The cool name for it is the SUP-ICU trial. There are a lot of memes that have been going around the internet for this, and I think they're quite entertaining, but I don't want to copy anybody's work. So, yep, the SUP-ICU trial. Before I begin, to introduce myself to those of you who don't know me, my name is Eddie Joe. I'm an intensivist. These videos are for educational and nerdy entertainment purposes only, and they are not recommendations on how to manage your patients. I leave that up to you. Please read the articles yourself, and please don't trust me. Don't trust what I tell you, even though you do see the article right here. Yeah, don't trust me. You read this on your own. You've been warned. Now, if you learned something from this video, please click the like button and subscribe if you haven't already. Thanks in advance for checking out my video. I'm trying to get better at this every day, so this is the first time that I try this screen capture type of approach to it. I'm also on the Instagrams and I'm on the Twitters if you're into those types of things. So let's go. As I mentioned, this article is titled, Pantoprazole in Patients at Risk for Gastrointestinal Bleeding in the ICU. Thank you to all these fine folks who did this research, because without you, I wouldn't be able to make this video. And today is November the 6th. I think today's a Tuesday or Wednesday. Yep, it's a Tuesday. And this article was published on October 24th, so it's very recent. Going over the abstract really quick, actually, I'm going to skip it because this is a free full article. What that means is that New England Journal of Medicine should not get pissed off at me because I am using their article online. It is free. You can download this yourself. You don't have to email me for me to get it for you. But basically speaking, and I don't know if you've seen this in your ICU rotations or if you practice in the ICU, but we basically give GI prophylaxis to everybody who is on a ventilator and who's critically ill. And that includes either using a PPI or an H2 blocker. Patients will get either of these two. And so what this article basically states is, and I hate reading to a little bit, but some people can't quite see the screen right now. I mean, if you can't, let me know, and I'll try to figure out a way to make it bigger, but I have these silly advertisements in the way. But nevertheless, it states that critically ill patients in the intensive care unit are at risk for stress-related gastrointestinal bleeding, which is associated with adverse outcomes. Yeah, definitely. And so to prevent gastrointestinal bleeding in these patients, prophylaxis for stress ulcers is used and is included in guidelines for patients who are at risk for GI bleeding. Now, those risk factors for the development of GI bleeding in the ICU include mechanical ventilation, which I do quite frequently in my own practice, actually almost 100% of the time, coagulopathy, and hepatic or kidney failure. And so it also discusses that PPIs are the most commonly used prophylactic acid suppressant in these circumstances, etc., etc. So the reason why this article is very important to me is because of this next sentence that's coming up over here, which states, concerns have been raised about adverse effects associated with this class of drugs, including the risk of C. diff, because there's been some data that shows that PPIs increase your likelihood of developing C. diff, well, not yours, but your patients. Pneumonia is another one, and this one was kind of new to me. I wasn't sure about this myocardial ischemia one, so this one is new to me. So they conducted the stress ulcer prophylaxis in the intensive care unit, i.e. the SUP-ICU trial, to evaluate the effects and adverse effects associated with prophylactic use of PPIs who were at risk. So that's where we get started. Now, discussing the methods, I'm going to kind of blaze through this because this is kind of like the boring and unsexy part, but the part that is pretty cool about this is that this study with regards to enrolling patients didn't take that long. It was about almost 2 years. So from January 4th, 2016 to 2017. Another cool thing is that they got a lot of ICUs involved, 33. And a lot of different countries were participants of the study, including Denmark, Finland, the Netherlands, I can't speak, Norway, Switzerland, and the UK. And, here's all the nonsense that they usually describe here, because ultimately you need to get IRB authorization to be able to perform a study of the scale. And what it states is that's also important is that this was a multi-center, stratified parallel group, placebo-controlled, blinded clinical trial. Awesome. These are the great, sexy studies. This is why I'm talking to you about this today. Now, with regards to the participants, this is pretty standard. They don't use kids, patients who are 18 years of older, etc., who had at least one risk factor for clinically important GI bleeding, including shock, Anticoagulants, renal replacement therapy, mechanical ventilation, expected to last more than 24 hours. Excuse me. Any history of liver disease or any history of or ongoing coagulopathy. Okay, so these are the people who were screened. Amongst the nuances of this study, it doesn't quite say that they ruled out patients who were on PPIs before any type of stress ulcer medication at home, whether it be an H2 blocker or a PPI. Okay, so that's basically talks about the interventions, the participants, and with regards to the interventions, what did they do? Well, the patients either got 40 milligrams of Pantoprazole or a placebo. Okay, and that's what they did. Now, outcomes. It states here the primary outcome was death by 90 days after randomization. This primary outcome is a little bit troublesome because, first of all, patients who develop GI bleeds in the ICU, in the ICU generally don't die from their GI bleeds. When I, as an intensivist, call my gastroenterologist colleague and I say, hey, this guy's bleeding, they need to be scoped. Well, GI usually comes and they take care of it. They don't die because of their GI bleed, generally speaking. They die from a myriad of other issues, but not that. Okay. I'm going to talk about Josh Farkas's article on pulmcrit.org, where he talks about why the primary modality endpoint was inevitably going to be negative. And I'll put the link for his page below because I think you should definitely check out and read everything he writes because he writes good, clinically relevant stuff. Now, continuing on with the outcomes, the secondary outcomes were clinically important events in the ICU, which were defined as clinically important GI bleed, new-onset pneumonia, C. diff, or acute myocardial ischemia. Okay, so what did they define as clinically important GI bleeding in the ICU? Well, this was overt GI bleed with one of the 4 features. So it states that the patient had a spontaneous decrease in systolic blood pressure, mean arterial pressure, or diastolic blood pressure of 20 millimeters of mercury or more, initiation of treatment with vasopressor or 20% increase in vasopressor dose, a decrease in hemoglobin by at least 2 grams per deciliter, or the transfusion of 2 or more units of PRBCs. Okay. The infectious adverse events, which were very important to me, given how I've been kind of modulating my practice as of late to PPIs, include new-onset pneumonia or C. diff infection. And these other outcomes, serious adverse reactions in the ICU and percentage of days alive without the use of life support, etc. These were other endpoints that they had. Okay. When it comes to statistical analysis, I'm not going to get into the nitty-gritty of this. So I'm going to let you read all about these binary logistic regression, adjusted for trial site, etc. Okay. Now, with regards to the actual sample size, trial population, they had a total of about 3,300 patients, which is a lot of patients. Of those, pretty much split in half. 1,645 were getting a PPI and 1,653 were getting a placebo. It states here that during the 90-day trial period, which is where they monitored the patient for 90 days, they stayed in the ICU for a median of 6 days after randomization. They received the trial agent for 4 days or so, and talks here about the protocol violations. And this is the part that kind of bugs me a little bit, right? That they didn't very clearly delineate any outcomes with regards to enteral feeding. And the reason why I think that this is a little bit troublesome for this article and what it's trying to achieve is that there is a theoretical benefit for early enteral nutrition being another therapy to avoid stress ulcer prophylaxis. And in my practice, at least of today, November 6th, once again, this is not clinical advice. I usually start feeding my patients as soon as humanly possible to further avoid malnutrition as well as kind of like a stress ulcer prophylaxis. And a lot of times if patients are just on mechanical ventilation, something I do is just continue enteral feeding and take off the stress ulcer prophylaxis, especially if the patient was not on PPIs or H2 blockers prior to admission to the ICU. Once again, that's my practice. That's not clinical advice on how to do this. Okay. And it states that patients in each group received enteral feeding for a median of 4 days in the ICU. Now, let's talk about outcome. And here we're basically going to use statistical analysis for this. And it states that 90 days of recommendation, basically all-cause mortality in 90 days was 31% in the PPI group and 30.4% with a p-value of 0.76. Therefore, there was no mortality benefit to using a PPI, which is something that we had kind of expected to see here. It also states that a total of 360, well, just make it easier, about 22% of patients in the PPI group and 22.6% of the patients in the placebo group had one or more clinically important events in the ICU. Of those, 2.5% of the patients in the PPI group had a clinically important GI bleed, as compared to 4.2% in the placebo group. The article states that these particular values don't have p-values because of lack of adjustment for multiple comparisons, and then they delineate this a little bit more in the supplementary appendix. Now moving on to the discussion. So, reading along this, it states that in this international blinded placebo-controlled randomized trial involving adult patients in the ICU who are at risk for GI bleeding, we found that 90-day mortality, percentages of days alive without the use of life support, and number of patients with clinically important events, infectious adverse events, or serious adverse reactions were similar between those treated with a PPI and those who received placebo. It does state that fewer patients in the PPI group than in the placebo group had clinically important GI bleeds in the ICU, and the 95% confidence intervals for the relative risk did not cross 1. Okay, and I think that there's another particular, I think it was here, Josh Farkas wrote that the number needed to treat. Let me just scroll down here. Here we go. Look, here's one of the memes. That's Mark Wahlberg. Yeah. Anyway, so the number needed to treat is 59, which, as Josh Farkas says, that's not impressive. These are my favorite parts of these studies, and once again, this is continuing along on the discussion. The authors wrote that our results are similar to those obtained in a recent network meta-analysis in which no significant differences were found in the rates of death or infectious complications between patients receiving placebo or no prophylaxis and those receiving proton pump inhibitors. The latter group, however, did have lower rates of clinically important GI bleeding. Now, something else that was saying that the study showed is that the results of the current trial did not reproduce those observational studies which have suggested an increased risk of infectious complications. That's where I was talking about the C. diff or pneumonia, and myocardial ischemia in association with the use of proton pump inhibitors. They found that there were no significant differences between the PPI group and the placebo group in the rates of these events in the full trial population. They did find an interaction, however, between the intervention effect and the disease severity that suggested higher 90-day mortality amongst the patients who had more severe disease and received pantoprazole, which they state this may be a chance finding, but it warrants for further study. Now, the strengths of the trial include a large sample size. These people did great. Getting over 3,000 patients enrolled in this. They also had a great variety of ICUs, all in Europe, as I mentioned before, in the countries involved, which reflect different practice patterns, which was great. The trial was also pragmatic, so routine practice was maintained except for the prophylactic use of gastric acid suppressors. Now, here's why I always like the forthcomingness of the authors to talk about the limitations, okay? And in this particular case, they talk about the trials, including the lack of assessment of other medical interventions and the limited power of the trial to detect differences in some of the outcome measures and in the subgroup analyses. And once again, this is where using mortality as a primary outcome is troublesome because it's going to be very difficult, especially in an ICU population, to gather so many patients that you would actually be able to find the mortality difference. Okay. They also talk about the absence of reported serious adverse reactions to PPI suggests underreporting, which may have occurred in another large trial of glucocorticoids in the ICU setting. Other thing that they did, which, this is real world practice and I guess this is what the pragmatic part of this is, that they did not mandate diagnostic endoscopy to assess the source of bleeding and were therefore unable to differentiate between stress ulcers and other causes of GI bleeding. And I oops, as I struck the microphone here, I kind of like that they did this, even though it is a limitation, because in the real world, we do not necessarily scope everybody who has a GI bleed. That's just the way my practice is. That's the way that my gastroenterologists work. That's not medical advice. Geez, I'm full of disclaimers today. That's just how real world practice is. Other things that they admitted to was the fact that some baseline variables differed between the groups, and they did not determine whether patients had used acid suppressants before ICU admission or were receiving enteral nutrition at baseline. This is actually pretty darn important because, as we all know, the half-life for PPIs is much longer than that of H2 blockers, and when a patient comes in critically ill, they may have some PPI still in their system. Now, this enteral nutrition factor is also pretty important for the points that I had mentioned earlier. All in all, they concluded in this trial involving adult patients who were admitted to the ICU for an acute condition and were at risk for a GI bleed, they found no significant differences between a PPI and placebo with regard to 90-day mortality or the number of patients with composite outcome of 4 clinically important events. And this is a quick review of the SUP-ICU study. Now, there is an editorial that was written by Dr. Alan Barkan, also published in New England Journal of Medicine. And it's always very cool to, it's cool to me because I'm a nerd, but it's always cool to read these particular editorials because you learn a lot from them. And we're going to quickly go through this. In this gentleman's editorial, he states that critical illness can disrupt local and systemic mechanisms that protect against upper GI bleeds, a condition that may be associated with increased mortality, particularly amongst patients receiving ECMO. He talks about how this evaluation of PPI is timely owing to a number of considerations. States that stress ulcer bleeding may be less prevalent than it was in the past. That's because we're doing a better job in the ICU. And second of all, the overall benefit from PPIs may be reduced by adverse events that are associated with the use of these agents, including nosocomial pneumonia, C. diff, enteritis, and myocardial ischemia. Third, it states that the administration of enteral feeding in parallel with bleeding prophylaxis may reduce the risk of GI bleeding, which is what I discussed earlier, possibly obscuring the benefits of PPI. And conversely, the combination may increase the risk of nosocomial pneumonia. And he talks a little bit about some previous study that occurred in the past, and ultimately he recapitulates that there was no significant difference between the two groups for the primary outcome, and states that the observed mortality rate was higher in the placebo group of the current trial than in the cohorts used to calculate the sample size for this trial. Now, it also states that there was no difference found with regard to the secondary unvalidated composite outcome of the clinically important GI bleeding, nuanced pneumonia, C. diff, or acute MI. It states that the trial was not powered to address each component of the combined secondary outcome, thus limiting conclusions. Useful new information can be drawn from the findings. Here's where we get a little bit juicy. It states that clinically important GI bleeding occurred in 2.5% of the patients in the PPI group and 4.2% of the patients in the placebo group. The magnitude of this possible benefit of PPI is within the range of differences between PPI treatment and the placebo for GI bleeding prophylaxis that was shown in a recent meta-analysis, although the rate of clinically significant bleeding in the placebo group in this trial was greater than the upper 95% confidence limit of the bleeding rate in the cohort analyzed. Important to note here that the combined rates of the infectious outcomes of pneumonia and C. diff infection were essentially identical in the two groups, where it was 16.8 in the PPI group and 16.9 in the placebo group. Now, if you were to ask me how this study would change my practice, I would basically go ahead and agree with this particular author of this editorial, where he states over here, the take-home message from this trial is that given the low incidence of clinically important upper GI bleeds in the ICU, prophylaxis with a PPI, if initiated, should be reserved for seriously ill patients who are at risk for this complication. Doesn't mean just give it to absolutely everybody who's in the ICU, but just give it to people who are at high risk for this complication. And that's pretty much how I've been practicing in the past, and this is how I will continue practicing it in the future. However, the most important part of this study, at least in my opinion, is the fact that there isn't as much C. diff and nosocomial pneumonias associated with PPIs as was previously described. And I will go ahead, and link this article written by Dr. Josh Farkas on mcrit.org, where he basically talks about the endpoints and how stress ulceration in the ICU doesn't affect mortality. And I'll just let you kind of take a look at this article that he breaks down on his own. So ultimately, I hope you learned something. Thank you for checking out my video. Hopefully this format is useful to you. I know I watch other videos where people scroll through articles and basically highlight key points off of it. Let's just see how this goes. Thanks for watching, guys. Bye.